We're going to introduce ourselves. I'm Rebecca Andrews. I'm a primary care physician at UConn Health, and I'm also the physician lead for the Connecticut Comprehensive Pain Center. We are here today giving the third of about 6 talks through a grant from the Connecticut DPH to try and go over all things pain related. If you see the website that's at the bottom of this screen, you can access our first 2 talks there and either watch them or rewatch them. The first one was on identifying causes of pain and tailoring treatment, and the second was on safe opioid prescribing and some additional details on medications. I'm going to let my colleague introduce himself, and then we'll get started.
Good evening, everyone. I'm Kevin Chamberlin. I'm a clinical pharmacist that works in the pain management arena and serves on the Connecticut Comprehensive Pain Center. Alongside Dr. Andrews, we have another primary care physician, Dr. Jen Ozimek, and an addiction psychiatrist, Dr. Sarita Rao, who I believe is on the panel with us this evening as well.
All right, before we get started, I am actually going to turn off the video just so that we can make sure that you can see the slides and the transmission of sound is good. So to start with, I'm just going to review some of our objectives today. Today's talk is going to focus on identifying appropriate reasons for tapering someone who happens to be on chronic opioid therapy, understanding the methods of tapering, and hopefully we'll do that through some patient examples, identify methods of managing withdrawal symptoms with some adjuvant medications. And like I said, the 2 cases that we have, one will go over an easier or more straightforward case, and the other one might be more relevant to some of the more challenging cases you'll see. And then hopefully we'll have about 10 minutes for questions at the end. Okay, the first section of this talk is just reviewing some of the facts on pain and what actually makes it so complex. Treating coexisting conditions can really make a difference in pain intensity and pain perception, even outside of treating the pain itself. The 3 main conditions we wanted you to be aware of were depression, anxiety, and pain catastrophizing. In addition, we really wanted to highlight that there is a bi-directional relationship between sleep and pain. So even someone who did not previously have sleep conditions or sleep issues, once they develop chronic pain, it can now cause sleep concerns. There are screening tools used that can create an objective measure for depression, anxiety, or pain catastrophizing, and we can utilize these to see how effectively we are treating these. In addition, it's important to talk about the resources, support, and culture that surround the patient who's in front of you so that we can best utilize those to help treat their pain as well. So what makes chronic pain a little bit different than acute pain is we're looking more on the long term, what we're going to do for this patient. And although most pain management focuses on physical injury, this pictorial represents all the different components that go into a patient's ability to manage their pain. So for each individual, these circles may be larger or smaller depending on their personal profile, their genetics, their life experience. So for example, one patient might have a significant cognitive dysfunction that plays a role in their ability to manage their pain, whereas for another, it might be environmental stressors or what their work-life balance is. One thing that is really important to talk about, and to be honest, it's the one that I probably forget the most, is to remember to ask your patient how they would define success. If you remember from our other talks, we talked a lot about functional goals, getting the patient to focus on what it is they want to regain. But an equally important question is, what would success be for you? So would it be pain related? If I can reduce your pain by 30%, that would be what is most important to you. Is it again based on mobility or increased activity? Or maybe it's just a patient who wants to be able to sleep better at night. Sometimes we lose sight of this, but really setting the patient's marker of success will aid you both in knowing when you've had success with treatment, but also when it is time to consider tapering. This is a slide from one of our previous talks. We just wanted to highlight again how multimodal pain treatment is. So on the left-hand side, you have everything from physical modalities to manual therapy, therapeutic exercise that should be constantly in the work. Some of them might work better for your patient in combination or at a particular time, but utilizing those because their benefit, whether it's low, moderate, or high, comes with a lower risk than the medication that we have. On the right-hand side, you have the host of different medication categories that we use to treat chronic pain. Again, the cost to these isn't always just an out-of-pocket expense, but can be in the risk-benefit profile. So when we're treating pain, it's good to remember that we want to be as intentional when we're treating pain also as when we're stopping medications, which we'll be talking about today. We spoke in our first talk about trying to identify the cause of a patient's pain so that we could really tailor the treatment more effectively towards them. One of the things that we're hoping you walk away from this talk with is reducing the myth that a medication is stronger than another medicine, which a lot of my patients will ask me. It's important to realize that whether the medication you're treating your patient with is acetaminophen or an opioid, at best, you'll get a 30% reduction with one medication. When you know that and you look at treating concurrent mental health disorders, which we mentioned at the start of this talk, and you see that by improving depression, you can reduce pain intensity by 45%, it gives you the idea, which is correct, that by treating depression, you can actually do more for that patient's pain than by addressing their pain itself. With anxiety, you get somewhat of a drop, although I would say that 12% is nowhere near as beneficial as 45%. And then if you can work with your patient, especially with cognitive behavioral therapy, to stop pain catastrophizing, you can again reduce their pain intensity by 33%, having never touched their pain or given them a medication specific for their pain. I mentioned when we started that sleep and chronic pain have a bi-directional relationship. This is important because up to 80% of patients with chronic pain will have some sleep disturbance. And if they had a sleep disturbance prior to developing chronic pain, they tend to have a greater symptom severity, and these symptoms will last longer and be more disabling, as well as associated with more mental health comorbidities, such as the depression and anxiety mentioned in the previous slide. Proper sleep disturbance treatment is really important to improve pain and their outcomes. So think about screening for obstructive sleep apnea just as you're screening for depression and anxiety. And do remember that this is proper sleep disturbance treatment, and currently CBT or cognitive behavioral therapy is first line for insomnia. So while we're talking about cognitive behavioral therapy, it's important to note that this is a tool that is really useful to patients for everything from insomnia to chronic pain. Specifically with chronic pain, though, it's a finite number of sessions, about 6 to 8, that last either an hour or 2 hours. Some of this is done or could be done in a group, or your patient could choose to do it on an individual level. Currently, there are even online programs. The important thing to note here for CBT is to garner your patient's investment in it. It is a limited time experience. It works on both pain and sleep, and it does reduce relapse and reduce pain. Mindfulness is a similar theory, but really thinking through and getting rid of negative thoughts that can put you into a cycle of worsening pain and then the pain catastrophizing that we talked about sooner. Physical therapy and massage or other modalities, it's just important to note that physical therapy needs to be continued into an active lifestyle, and as long as the patient is physically engaged, they'll gain benefit. Passive physical manipulation is only effective for the short term, that it's ongoing, but not after the fact. So we've gone over this information extensively. We tried to put some key points for each class of medicine here, such as targeting the most appropriate dose for acetaminophen or trialing multiple subclasses of NSAIDs if one did not work or did not work well enough, and that peripherally acting muscle relaxants have limited benefit with long-term use. Again, if you go to the second talk that we did that's on the website, you can get more in-depth information on each of these points.
So now that you have a reminder of what's in your toolbox, we're going to make a brief stop and talk about acute pain to kind of tie things together from those previous talks before we delve into the tapering strategies. Even in acute pain, you need to set expectations for pain relief and expectations for medication discontinuation at the start of therapy. You want to treat it because undertreated acute pain can become chronic. And as you'll hear us say again and again, you'll want to be intentional with both your plan in treating the pain and with the de-escalation of therapy. Remember, opioids are not a cure-all though. The probability that a pure mu opioid receptor agonist will achieve a 25% reduction in pain without causing respiratory depression in a drug-free, healthy adult is 70%, according to a study from Anesthesiology in 2018. In other words, you have a 50-50 shot at getting up to a 50% reduction in pain. The mean relief achieved in that study was not over 40%. A summary of the steps that you need to take before prescribing opioids are listed here on the screen. You need to identify and treat mental health conditions, screen for risk of addiction or overdose with any of the tools we showed you in our second talk, identify other high-risk medical conditions such as sleep apnea to limit harm, and the last consideration, the risk of harm to society, is actually best seen on the next slide. In considering the effects of opioid prescribing on society, we have to look outside of the one patient that's in front of us. In 2015, almost 100 million Americans were prescribed opioids by their doctor. And a recent survey showed that a third of those who abused prescription pain medications in the past year got pills directly from a physician. This abundance of pills, if you will, impacts the community at large when excess pills are sold, stolen, or simply given to others. In fact, receiving painkillers from a friend or family member was the most common pathway to abusing opioids. We'll call it the friends and family plan, if you will. This slide here shows more opioid misusers received their medications from a friend or a family member than even a physician, 38 to 34%. So when you do prescribe, using only the necessary number of pills is vitally important. Not all acute pain requires treatment with opioids. A major barrier to appropriate dosing of opioid analgesics is that it's pretty difficult to predict the intensity and the duration of pain after, say, an injury or surgery. Pain varies depending on the type of injury or surgical procedure, patient demographics, cultural ethnic factors, prior history of alcohol, drug, or opioid use, obviously, and history of anxiety or depression. So if we put this all together with what we know people might do with their extra medications, specifically in that acute pain kind of setting, we should be prescribing a limited number of pills with a clear description that does not simply write, take it PRN. So for example, the first 2 days out of surgery, maybe we schedule the dosing as Q6 hours, but then the de-escalation begins immediately. So you go to Q8 hours, maybe for another day or two, then Q12 hours for a day or two, and then once daily and or done. See, kind of stepping down right after you start. Johns Hopkins also created dental recommendations that are shown here. And these suggestions are really important for maybe our teens and young adults, as these are opportunities for these patient groups that are where they're potentially first introduced or re-exposed to opioid analgesics. So those last two slides were the Hopkins guidelines for duration of use or quantity prescribed. And now it's going to make clearer sense. The reason we spent so much time about short-term prescribing, it's highlighted right here on your screen. Almost all the guidelines will say less than 7 days in acute situations or as a first trial for pain management. And as you see here, at about 5 days, the likelihood of dependence increases. Honestly, you should also look at 3 years out. So nearly 25% of those patients that were prescribed opioids, they're still on them if they were given a 1 month supply at the initiation. Multiple studies have shown that excessive opioid medications are routinely prescribed for all types of surgical procedures, as well as after emergency department visits for painful conditions. And most patients save those leftover pills. As a result, you can imagine there's large amounts of opioid tablets that are then available for diversion. So let me give you two examples that are in the literature. A study out of Michigan had 2,300 surgical patients. They had a higher prescription quantity. They identified rather that a higher prescription quantity was associated with higher patient-reported consumption, but they couldn't necessarily confirm the causal relationship. The second study was 250 patients who underwent upper extremity surgery, reported that most patients received a prescription for 30 opioid tablets postoperatively. 77% took half or less of the prescribed pills, and 45% took less than 5. So if you do the math, the total number of unused tablets from those 250 patients, 4,639. So in finishing this section of the talk, it'd be helpful if you haven't already to go back and review our previous 2 talks for a more in-depth review of how to approach pain that are posted both on our website and linked here.
I promise you that we are not anti-pharmacotherapy, given that Dr. Chamberlin is a PharmD, but I do want to acknowledge here that there are significant limitations of pain management. The reason it's important to acknowledge this is it sets your expectations as much as the patient's, instead of just adding medications or increasing doses and therefore increasing risk of adverse drug effects. You have an idea of what's going to happen and what you should expect. So just to review the most salient points, there is a limited pain reduction, about 30% for any one medication, even if it's effective. There is a significant risk of side effect, including respiratory depression, to obtain greater than 50% pain relief using opioids. There are significant benefits of treating depression, sleep disturbance, anxiety, and pain catastrophizing without any analgesic-directed interventions that is essentially equivalent or greater than medication use for pain intensity. And finally, overprescribing opioids can have effects not only on the patient, but also their circle of friends and family. So are opioids indicated at all for chronic pain? Unfortunately, it's not that different than what we see in studies that are in the literature for acute pain. A Cochrane database review from 2010 showed that at best, opioids had a modest effect on pain with no substantial improvement in physical function. So to be explicit, 50% or less benefit for pain at 3 months of opioid use, and only 12% or less of patients have an effect from chronic opioid use at 6 months. Yet we see people maintained on opioids for years and even decades.
So actually, if we ignore the time of prescribing and just look at dosing, the literature shows that a dose of 35 morphine milligram equivalents is the mean effective dose for pain. A case series actually found the same thing, with the cutoff being less than 40 morphine milligram equivalents for effect. Additionally, evidence from an observation-based study found a 9-fold increased risk of overdose at doses greater than 100 morphine milligram equivalents compared to 20 morphine milligram equivalents. And for each overdose death, there were more than 7 non-fatal overdoses. We'll come back to overdose risk a little bit later. And if you're using the evidence, currently the low-risk meds perform at least as well as opioids, based on the 4 studies listed here from 2010 to 2018. So in summary, there's a lot of evidence against chronic opioid use as an effective analgesic option for chronic pain patients.
So knowing that, that means that you have to be willing to do risk reduction at the start of initiation. So how do we do that? So before you do prescribe, your patients really need to know from the start that they will be tapered for a host of reasons. It's nothing that they did wrong, but if they don't reach their goal after having effective treatment doses for several months, remember the slide concerning the lack of evidence for long-term effect, then we should probably taper them. If they fail to reach whatever goal that is a functional goal or the goal that they've used as a measure of effectiveness of treatment, If they have an adverse effect that shouldn't be tolerated or is dangerous, we should taper them. If they've had an intervention for resolution, such as surgery, we should taper them. And then, of course, there are the things that everyone worries about, such as diversion. So this is basically your exit plan. And when you get on a plane and you take off to fly, you know you're either landing where you plan or you're being diverted, but you hope you land safely at each. And that's an example of what we're trying to do here. Opioids are really always a trial. So some of the reasons you should then go over with your patient that are really important are that opioids can actually make you worse. So hyperalgesia needs to be explained to patients. Patients, as we talked about in our first two talks, have the idea that opioids are stronger than other medications, and what they don't realize is they can also sensitize you to pain. When is the last time you warned your patient you were starting on an opioid about urinary retention, or that they could cause chronic abdominal pain or gonadal suppression? Because those are all side effects of opioid use. And often we use them when either we, the patient, or both of us are frustrated that we can't get adequate treatment, an adequate level of function for our patients. And unfortunately, that happens most in the challenging conditions that you see listed here, like fibromyalgia, chronic abdominal pain, Ehlers-Danlos. And those are the conditions when opioids actually have the least evidence behind or are advised against. There's a recent study that discusses the development of depression and anxiety in patients who are using chronic opioids who did not have those conditions before. And on the flip side, the euphoria of opioids might treat depression enough that you miss diagnosing it and starting a treatment. And so think way back to the beginning of this, treating depression can reduce pain intensity by 45%. So we actually want to diagnose it and treat it. Additionally, there was a population-based study that showed a poorer quality of life and physical function and pain control in patients who are maintained on chronic opioids.
Outside of lack of evidence for effectiveness, we have to consider the current opioid epidemic. The thousands of overdose deaths around the country are the most extreme symptom, but the problems run much deeper. In 2017, there were over 11 million opioid misusers in the United States. That's the entire population of Ohio and nearly 3 times the population of Connecticut. The healthcare burden of the crisis is also staggering. The cost of opioid abuse is $10,000 to $20,000 in annual medical costs per patient. And the opioid epidemic is projected to claim nearly 500,000 lives over the next decade alone.
I'm going to feed off that for this next slide, because I do think as physicians and prescribers, we have to be cognizant of this article. This study came out from the Annals of Internal Medicine in 2016 that showed even after an overdose, non-fatal overdose, clinicians continue to prescribe opioids for patients. 91% of the patients in this study received prescriptions even after they had that non-fatal overdose, and 70% were from the same provider. Of those 91% who had a non-fatal overdose, 7% had a second overdose. And if you drill down on this cohort, you see that that was the group on higher dose opioids or a concurrent benzodiazepine. So in summary, basically what we're trying to say here is there is limited evidence for chronic opioid use, but both patients and prescribers cling to them as an option. So if you are prescribing them, you need to be clear with your instructions, the risks, and the boundaries of when you would continue or stop them right from the get-go. So expectations for pain relief. Discuss with the patient. 30% is the likely reduction at maximum. So if they're in your office at a pain level of 10, that's a 7. You are not getting them below a 7, so we have to look at alternate opportunities to make them better, such as treating mental health conditions and helping them with CBT and mindfulness manage the pain. We have to talk about risks of dependence and overdose, especially if there's a family history. The side effects of opioids that the patients are not considering when they're looking for pain relief, such as gonadal suppression, chronic abdominal pain, those things that really affect the quality of life. Think about the importance of additional or alternate treatments to reduce those risks. We should give them specific instructions. How do they take their opioid or their non-opioid medication, including how to decrease it and stop the medication. And patients should be educated that opioids are only to be used when non-opioid options fail to provide adequate relief. Again, I'm just going to say it, as a trial, not to be used permanently. The pharmacist and the team would say that we need to talk about safe storage and disposal, and I'm just going to say that prescribers are probably the worst at this, but talk to your patient. How do they give back the medication so that friends and family plan isn't a part of their friends and family? Whether it's gel inactivators, mail back programs, going to the police department, etc. And then lastly, we really need to write out instructions and risks and benefits in layman's terms so your patients can go home and use that as a guide. So talking about opioid tapering is easy. It's a little bit harder to put into play. The last time we did this lecture, someone asked us what we do when someone doesn't want to taper, and I'm sure we'll get that at the end of this talk as well. But each patient is a different experience, different interaction. There are different components that go into it, and there's a different set of hurdles for each person that you have to sort of uniquely navigate, not unlike someone who has multiple allergies to antibiotics who presents to you with a UTI. So let's walk through a few different scenarios. So here's a patient who's 57. He has osteoarthritis of his knees, so something you probably see a lot of, and he works a physically demanding job. Your patient has done his due diligence. He's done weight loss, exercise with aquatherapy. He has trialed all the low-risk medications, but he's still in pain. He's a sole income earner for his house, and he needs to be able to work his job for another 8 years until retirement. So you start the conversation. You talk about the parameters and the metrics you'll follow if you start an opioid, the risks. In the end, you decide between the two of you that trying an opioid for a week or two, followed by reassessment, is the next step. Your conversation really needs to hit on the fact that this is a trial with limited effectiveness, a medication agreement, which is not legal or binding. It is not a contract. It's a treatment agreement. You have to screen for depression, anxiety, and their opioid addiction risks. The state law in Connecticut and in most states across the country is to check the state database, but you should tell your patient why you're checking, what you're looking for, because it might prompt you to talk about other high-risk medications. And you should really set a functional goal and a plan for when you would stop the medication, again, right from the start. So this is pretty much what it looks like in the office. Mr. X, you've completed multiple courses of physical therapy, and we have tried a couple of low-risk medications with you, but we really haven't improved on your pain. Your goal is to work full-time, and I want to support you so you can support your family. The orthopedic surgeon does want to do surgery, but they want you to lose some more weight before they consider it, and it's reasonable to discuss what the risks and benefits of a low-dose short-term opioid pain medicine would be. We would start with 2 weeks and then bring you back in to reassess. But I need you to understand, at best, we might get your pain down from an 8 to a 5, and the medication will be stopped at the time of knee replacement, or if significant side effects occur, even if providing relief to your pain, or if there's any evidence of misuse, or really if the pain relief is not enough for you to reach your goal. So remember, when you start someone on opioids, that you are taking them down a path, as Dr. Chamberlin put up. Once you give them a 30-day prescription, they have a likelihood and a high likelihood 3-4 years down the road of still being on that medication, whether it was intentional or not. And what happens is, if you retire, if you move, if you cut down your clinic hours, you now have someone who's on a high-risk medication that another prescriber might not be willing to prescribe. So you have to address this at the time of starting it as well. We talk about compassionate deprescribing, which is slowly doing a taper so that they are comfortable when it's time, but you need to at least also discuss this with your patient as well at the time of starting the medication.
I think we can all acknowledge that opioid tapering is probably a pretty scary time for patients. And for you as a prescriber, you might be worried about your patient turning to illegal means for pain control, or the thought that maybe you're abandoning them in their pain management treatment. But really, tapering can reduce the development of tolerance and really offer the opportunity to assess continued need of a high-risk med. Additionally, reasons to taper are varied, and we've discussed some, but they can range from alleviating those unacceptable side effects to reducing the potential for diversion of medications or actual diversion, but also address the failure to reach that functional goal and meet the desire for less risky medication use. Tapering should begin by decreasing dosing milligrams first, followed by the frequency of dosing. So I'm going to read that again. Tapering should begin by decreasing dosing milligrams first, followed by the frequency of dosing once at the lowest milligram option. And if it's not tolerated, then we decrease to the lowest acceptable dose and then decrease the frequency if able. We're actually going to illustrate this over the next couple of moments. We're going to go through at least 2 examples of ways to manage an actual taper. So first, you need to decide fast versus slow. So the biggest consideration to first address is the patient's willingness. Second, perhaps maybe only to patient safety. So items in green on the left that might lead to faster tapers are inclusive of previous risky behaviors such as accidental or intentional overdose, suicide, diversion, a urine tox anomaly. And additionally, more rapid tapers might be necessary for those patients converting to treatment for opioid use disorder or those headed for incarceration. But rapid tapers can cause withdrawal effects, and patients should be treated with adjunctive medications to minimize these effects. And at times, you may need to consider admitting the patient for possible inpatient care during this process. If patients are prescribed both long-acting and short-acting opioids, the decision about which formulation to be tapered first probably needs to be individualized based on things like medical history, mental health diagnoses, and patient preference. But data does show that the overdose risk is greatest with long-acting preparations versus the short-acting immediate release ones. Slower tapers may be dictated by the list on the right in yellow. The need for change to the existing regimen, for failure to achieve or even actually accomplishing the functional treatment goal, but also concomitant high-risk meds could dictate a need for a more deliberate taper, things like benzodiazepines or other CNS depressant agents, or even other drugs that might have augmented the metabolism or clearance of the opioid in its presence or absence. So this is a busy screen with a lot on it, and I zoomed in a couple of quick images, but I want you to understand the takeaway point is that there are actually 4 recommended strategies that you can consider for taper. So slowest all the way to the left versus rapid all the way to the right. So if we zoom in on the 2 to the left, the slowest taper and the slower taper, typically, like I said, we should generally begin by first decreasing dosing milligrams, and then followed by the frequency of dosing once we're at the lowest milligram option for that dose. If it's not tolerated, then we would decrease to the lowest acceptable dose and then decrease the frequency if able. Published evidence illustrates success for patients on high daily doses and a willingness to taper, meaning there's buy-in. And many of the medications used to alleviate the withdrawal symptoms like opioids need to be used in caution in our elderly patients. So let's put this into perspective. You have a 53-year-old male who underwent hernia repair 2 years ago, and he unfortunately suffers from chronic nerve pain in his abdomen from the surgical mesh, and surgical revision didn't relieve his pain. He's on gabapentin 300 TID. He's on morphine controlled release 30 milligrams twice a day, and morphine immediate release 15 milligrams every 12 hours, giving you a 90 morphine milligram equivalency. The morphine's no longer helping him. He's severely constipated, and that further worsens his pain. The gabapentin, he says, might be helping, but he really didn't tolerate any higher dose because he felt out of it. His anxiety level's high. He's angry. He's sad in the surgical outcome and whatnot, and he struggles with his daily functioning. He had to retire early because he could no longer sit at his desk job or concentrate. He has poor sleep quality. And his life has changed drastically since before the surgery. So he's here asking you for help to wean from his morphine and what to do with the leftover medication. The basic tenets of opioid tapering are first to individualize your plan. There's no cookbook, black and white, step-by-step approach. You can go as slowly or as quickly as the situation permits or demands. You employ non-opioid analgesics to augment the transition off an opioid-focused regimen. And a good rule of thumb is that a reduction that approximates about 10% of the original dose per week is a good start, but you have to realize that in some, it just might still be too fast. Further, if you think substance use disorders are part of it, then the best thing you can do for your patient and for you is to refer the patient for further assistance and or begin Suboxone prescribing if you feel comfortable with the new regs around that. Now that you know the numbers and the data behind opioid limitations, you can provide encouragement as your patients taper while keeping in mind there could be a psychological dependence process that you need to also work through with them. So remember Mr. Martinez, he's on that morphine controlled release 30Q12 and the immediate release 15Q12 as needed, up to 90 morphine milligram equivalents a day. If we walk this over a 4-week step down, he would reduce during the first week from 30 twice a day to just that 30 milligram controlled release in the morning and step down to 15 milligrams at bedtime and maintain the immediate release PRN. But by week 2, you've now halved the controlled release dosing. So he's at 15 milligrams controlled release twice a day and still has that 15 milligram immediate release to use twice a day as well. By week 3, this is where you're removing a dosing though. In the morning, you might have him at 15 milligrams of the controlled release and only have the immediate release that twice a day as the only other medication he has available to him that day. And then by week 4, he's left with just the immediate release, maybe once a day, and then he's done. A 4-week semi-rapid taper. But here's another taper possibility. This is the one that when I recommend this during our Monday pain team meetings, these get a lot of eye rolls. But there's a lot of data behind the need for slow tapers in a number of individuals, and I think perhaps the daunting part of this is it takes you 14 months to get the patient off. But you get buy-in. So I know it's slow, I know it's deliberate, but there are some things to pay attention to, and I'm going to zoom in. So here we decrease just 1 midday dose of the extended release during the first month, and we maintain the rest of the regimen as it was. Subsequently, in month 2, we also decrease the evening extended release dose. Then month 3, we get all 3 scheduled immediate release or extended release rather, down to the same 20 milligram dosing and decrease the immediate release by 5 milligrams. And we held it there for the month. Then we took a similar approach, dropping a midday dose, then an evening dose, and then the next month, and then the AM dose, et cetera, et cetera. So by month 12, the patient was then only on an immediate release based regimen. And depending on the actual as needed usage at that point, we can map out the remaining taper. In general, procedures and injuries that involve bones and joints are more painful than those that involve soft tissue. There's a number of studies that have been examined that examine the degree of pain or the quantity of opioid required for pain relief after specific ambulatory surgical procedures to know the amount to send them home with. It's really the basis of those Hopkins guidelines that we showed earlier. Most are single institution studies though, and most don't report the use of non-opioid medications or analgesic techniques like local anesthetic infiltration or peripheral nerve blocks. But remember though, the indication is not for a 20-tablet prescription to take every 8 hours as needed. This is a take 1 every 6 as needed for the first couple of days, then step down to every 8 hours a day as needed, and then twice daily, tapering off realistically in that first week or so post-surgery. But remember, withdrawal and tapering off comes with its own set of symptoms, even when conducting a deliberate taper. So you got to remain empathetic, and that's key to the entire process. So keep in mind that some patients will have prolonged symptoms, similar to how a patient being tapered off maybe an SNRI or an SSRI might have a lengthy withdrawal period. In our own institutional toolkit that we've created for our prescribers, we've written up guidance to assist with managing their patients' symptoms as they arise. So here, for example, autonomic symptoms. We consider clonidine as our go-to first-line agent, but we also warn and remind everyone that it requires blood pressure monitoring and should be evaluated regularly with a targeted duration of use for less than 2 weeks. An alternative, though, we also recommend, and it might be baclofen in this case, which can have the benefit of also decreasing cravings after withdrawal. Gabapentin, like baclofen rather, has renal dosing guidance, so we need to be aware of that. It's also similar to baclofen in that it has secondary benefits, so it can be used as an analgesic, but also employed as an anxiolytic or even a sedative that can assist with sleep disturbances. At the bottom of the slide, we have two antihistamines that are listed for consideration, and they can have multiple effects as an anxiolytic and as an antihistamine. For myalgias, treatment is as expected. Consider the utility of both NSAIDs and or acetaminophen, or even topical agents that are aspirin or lidocaine based. The remaining symptoms have straightforward options for consideration. So low-dose trazodone can assist with sleep, or standard antiemetics for nausea management.
So we're going to do a second case scenario here, and this one's a little bit different than the first. This is a woman, Miss Bloom, who has some psychosocial complexities, which I put on the slide, aka real world. Obviously, not all of our patients do, but especially in the pandemic time and post-pandemic time, I think we're seeing this more often than we're not. So she was a 38-year-old female who had a long history of pain after a knee injury at age 17. From a sports injury. She'd been treated with a variety of medications, but really was started on opioids right at the start because of the severity of the pain when it occurred. She had self-tapered several times over the years, but returned to chronic opioid use in this pattern that we could see. So it was after she would get a prescription for maybe codeine cough syrup after a viral bronchitis, or if she got another pain medication prescription for another acute issue, and then she would end up back on it for a while and then eventually self-taper. So there were so many concerns here when we first discussed the case. You know, one of the things that pops out at me is the physician prescribing. So here's a 17-year-old, really young, who ended up started on an opioid without any regard to, say, NSAIDs or Tylenol, and then she was continued on it for a long period of time. It's concerning that, you know, prescribers would hear that she self-tapered and that it took her a while and still use controlled substances for things such as a cough, and then fail to see that that was the cause of her recidivism. Another thing that was in her profile were her use of other high-risk medications. And then, you know, at the bottom of the screen, she did have some legal issues and she was struggling at the time that we met her and not working. The thing that I want to point out, though, is that hindsight really is 2020. So if you look back to when she was started about 21 years ago, the lay of the land was very different. It was more about partnering with our patients against pain, prescribing for a pain level of 0, using a combination almost like insulin therapy where you have a long-acting and then breakthrough. There were really limited concerns with concomitant medications, and opioids were used frequently for teens for dental procedures. If you fast forward to now, we always use low-risk medications first because we understand the long-term effects of using opioids. We treat acute pain more aggressively so that it doesn't turn into chronic pain, but then we quickly taper instead of continuing. And again, after surgery, not prescribing these high volumes of opioids. We have a box warning for benzodiazepine use, and you really have to review that in order to have your patient prescribed both a benzo and an opioid. And we now also know that opioids have surpassed marijuana as the top gateway drug. So the patient came to us on a variety of controlled substances, and looking at these, you can get an idea that she was not only untreated for certain mental health conditions such as anxiety, but she was given medication to combat the side effects of her opioids. So she was on high dose opioids and given Adderall to help stimulate her for when she was fatigued. She was on alprazolam for her uncontrolled anxiety. And then this includes some of those medications that Dr. Chamberlin presented to you that we then use to help mitigate some of her withdrawal side effects when we made a plan to taper her. So it is a little bit of a give and take when you're working with someone on a taper, especially with Ms. Bloom. We had some challenges. We sent her home with a great plan on how to taper slowly. And when we met back with her in about 4 weeks, she had completely tapered off her short-acting oxycodone, which I know sounds great, but we circled back to it time and time again for the rest of her taper when she was concerned that this was the cause of her not feeling well when she tapered lower on the methadone. So we sent her home with certain instructions, such as month 1, how to taper slowly so that she would hit that point of about 30 to 40 milligrams of methadone, which is about when people start to have withdrawal symptoms from methadone. But what actually happened is she struggled to get below 50. So we redirected on month 2, we set our goals, she was still very motivated, and we sent her on her way to taper for a few weeks, and then she returned back, and she had only really gone down by a total of 5 milligrams in her total daily dose. So we redirected again, we discussed the goals, we offered Suboxone, we actually spoke with her about the fact that she clearly had opioid use disorder long before she came to us, and that would be an ideal treatment for her. And she really wasn't interested. So we slowed the taper a little bit, and then she did sort of a yo-yo of going down and back up, and then down again and back up. So when we started this series, we said we were going to give communication skills to assist with all the challenging conversations that come with pain. So Adobe is a great framework you can switch into when the conversation, for lack of a better term, is sort of heating up or becoming charged with emotions running high. It's really all about trying to drill down what is the foundational cause of tension that you can feel in the room, how do you diffuse it, and then regroup and set boundaries. So I'll give you an example of what I used with this patient. I know it's hard to be worried about being in pain and dealing with your withdrawal symptoms that you've had in the past. You are motivated at the start of this to taper down, to rectify some of your legal issues. So how can I help you get to your goal? I want to be cognizant of your symptoms, but you cannot self-adjust your dose when we send you out with a plan. We need to discuss that there may be a component of opioid use disorder and initiate counseling and therapy for that. And so that's an example, obviously very compressed in the time that we have here today, but it gives you the essentials of the conversation.
Thanks, Dr. Anders. Another communication style that we could have used is like the 5-step framework, which it's often used as an intervention or behavioral change. It can be used like for quitting smoking or weight loss or changing medications. In this setting, the Wasan and colleagues version, though, can be particularly effective. So if you like it, you can really use it at any point, but it's probably could be super beneficial in these tapering situations. So 5 steps. First, acknowledge the problem. Allow the patient to vent uninterrupted in a private place. Agree on what the problem is. Affirm with the patient what can be done, and assure follow-through.
So just to go over a little bit of what Dr. Chamberlin just mentioned, if you're, in this case, when you're affirming what can be done, it would be that you can slow the taper, but you would still persist. So in the end with Ms. Bloom, she really felt she couldn't go below the methadone 35 milligrams total daily dose. She had had prolonged withdrawal symptoms before and just felt that she did not feel well enough to increase her function. And even with all of our boundary setting, even with all of her motivation because of her legal issues, she sought other treatment as her goal changed. We did offer Suboxone and methadone maintenance on multiple occasions, which she declined. And due to some of the psychosocial components, I actually am going to admit that I found it very helpful to have a team with me, which I'll talk about in a second, to sort of stay the line on the plan. I was very empathetic with her and I could see what her challenges were. And sometimes even though I know the right thing to do, what the right thing to do is, sometimes it really does affect how we are when we're in the room with a patient. So I will just make another ploy, set your plan at the start of your treatment for why you would taper, go back and read those notes to help you. And she ended up actually tapering off on her own. This is just a last slide before we finish the talk, just for sort of future mindset. There are a lot of new payment options out there, including collaborative care models. We are a team, and it helps on so many levels to have multiple people in the room, all making sure we're doing the right thing for the patient. Although we don't have a slide depicting it up here, there's good evidence in the literature that interdisciplinary teams actually address ethical issues more often. And so you can really walk away and know you did the right thing for the patient.
So with that, before we get into Q&A and maybe more of an open discussion, there's a big thank you that we owe to the Connecticut Department of Public Health, who made this conference possible through the grant funding from the Overdose Data to Action. So we look forward to having you and more of your colleagues at the remainder of our seminars over the next year or so.
All right, while we put the video back on, I will check to see if there are any questions. I don't see any yet, and while we're waiting, I think I'm just going to address the question that we got last time, which is a really good one. It was about, what do you do if the patient doesn't want to taper? So just like we try to normalize chronic pain, and we don't want our patients presumed to be seeking medications, or if they're seen by another provider, we don't want them to minimize their pain. We really want to objectify everything and destigmatize it. So I guess my question to you would be, would you have a hard time stopping lisinopril if someone had angioedema? And of course the answer is no, but we have a hard time here because pain is difficult to treat. I think one of the main goals behind these sessions is to get everyone to really understand and be on board with the fact that chronic pain is not going away. There are more patients with chronic pain than, heart disease, diabetes, etc. combined. We talked about it in our first slide set. And there is one board certified pain specialist for every 100,000 patients in pain. So this is a primary care issue, and we really have to try to approach it with the best objective evidence we have. So getting your patient to have buy-in, you really just have to go through the side effects. If you set the groundwork ahead of time, it's really good when it's time to have this discussion. So then you can go back and say, remember, if we didn't reach a goal, or if we had undue side effects, we were going to stop this medication. And I know that it is difficult. We will do it in the most comfortable way possible. But it is time to do it. And just keep telling yourself the same thing. If this was someone who had, a secondary side effect that was significant from any other medication, amlodipine with significant peripheral edema, or like I said, angioedema with an ACE inhibitor, you would do the same.
So a thought from Robin on the right.
So we have a food for thought. It is now known that diversion can occur if your home is for sale. So the Connecticut Realtor Association is now working with us on notifying homeowners to properly store medications. A potential buyer who's touring the home may be specifically looking for medications to take with them. That's from Robin from the DPH, and that's actually a great point. Part of what we go over with our patients is it's your job to store them appropriately and safely. They shouldn't be in your car hanging out. They shouldn't be in unlabeled containers. But that is a great point. Thank you, Robin. We also have a question. Do you want to read the question?
Sure. So I've had patients, this is from Tamika. So I've had patients that have been started on opioid therapy prior to becoming their PCP, and I continued them on a maintenance dose, but then they decided to start getting marijuana from a dispensary, so medical marijuana. So do you have any advice on these particular things? I will also say, I think Dr. Rao is on with our panelist discussion, so maybe we start and maybe Dr. Rao can weigh in.
Sure. So I would say that I actually don't necessarily continue a patient on their maintenance opioid. I try to get records to make sure that the cause of the pain has been appropriately evaluated. They've been through low risk med trials, et cetera. We don't want to strand these patients or leave them, but you're taking on the risk of a high risk medication for a new patient that you haven't met. You want to do your due diligence and be able to look back on that. God forbid anything undue happens, such as respiratory depression, etc. It's really good. This is one of the reasons I mentioned it in the talk. If you have a patient on chronic opioid therapy, let them know that this would be a difficult transition if, say, you move out of state and you have to think ahead to try to transition them to someone where you can do a warm handoff and get a sign out and make that new prescriber feel comfortable. So that would be the first thing that I would say is we do not prescribe on the first visit at our primary care offices or at the CCPC. We do a full workup. Medical marijuana, I'll turn it over to Dr. Rao in a second. It's so tricky because some states it's legal, it's still federally considered an illicit. Dr. Rao, do you want to join us?
I am here. Can you guys see me and hear me?
Yes.
Okay. Yeah, wonderful talk. First of all, let me just say, I mean, I've heard this talk now several times, and it's just incredibly good every time I hear it. Well, the medical marijuana question is complicated. I would say that don't do anything that you don't feel comfortable as a physician or a nurse practitioner. So you also have to look at the rest of their medications and kind of the global picture. So if this is somebody who, you feel is on other medications, either from you or from somebody else, like let's say they're on a benzodiazepine from their psychiatrist and they don't want to give it up, or they are on muscle relaxants, or they are on some other sedating meds or central nervous system depressants, then you have to kind of look at it in the context of all that. As a parallel example, which is not the best example because we're talking about people who have an established diagnosis of opioid use disorder, but let's say opioid use disorder patients who are treated with methadone maintenance therapy, OAT, agonist maintenance therapy. We're talking about people who have an opioid use disorder. Most methadone programs don't actually test for marijuana, for cannabis in their drug screens. It's a bit of a don't ask, don't tell, because if they really tested for cannabis, they'd probably have to do something about it or discharge a large number of their patients. For addiction medicine doctors and addiction psychiatrists who may prescribe buprenorphine for opioid use disorder as part of their practice, which includes me. I have some patients on buprenorphine. It kind of varies. I know patients who get their buprenorphine maintenance in large systems, and they are okay with medical marijuana. At UConn, if they're getting buprenorphine prescribed by me for opioid use disorder, I'm not okay with medical marijuana. I don't feel, my rationale is that if I have any concern, these are patients with an established diagnosis of substance use disorder. So I would not allow them to be on benzodiazepines. I would not allow them to be on Z drugs like Zolpidem. So why would I make an exception for this? Those are also medical. So you have to kind of make a decision. On the other hand, I have a patient in my practice right now. Sorry.
I think actually, no, that's okay. But I just think I would also add to that is, we've tried to give you the evidence as much as we can for this. I think the evidence for chronic pain on marijuana, medical marijuana and cannabinoids is still not mature. I do know that there was a rush to approve medical marijuana for anxiety that was not responsive to other treatments. And now a lot of the psychiatric organizations have said, you know what, that's probably not the best use. And Sarita, I don't know if you want to comment on that. We're almost out of time, but, you know, so, you know, the question, you're trying to use evidence and consider, like, is this worth the risk? Is it not? Is the benefit there? Is it not?
I would agree. And also I would say that, you know, this is my personal opinion as an addiction psychiatrist. I'm not representing the American, you know, it's not in my role in ASAM or anything else. I just feel like to some extent, the medical marijuana was a stop along the way to the pathway to legalization. It really would have been cleaner if the government wanted to legalize marijuana. It really would have been cleaner to have just legalized it the way they did for alcohol, because no one is saying that alcohol is medicinal, but alcohol is medicinal in small quantities for people who have a family history of heart disease. And it's also an anxiety reliever and a muscle relaxant and all of those things. If it was invented today, it would be a controlled substance. So, but we don't think of it.
On the flip side, there's still alcohol use disorder and there is still marijuana use disorder. So just because there is medical marijuana, so you kind of have to take all of that together and look at the patient in front of you. In our other two talks, we did not talk about it here. Before prescribing, you can use the opioid risk tool to sort of estimate what that particular person's sort of biopsychosocial and genetics are for developing an opioid addiction before you prescribe. And in part of it is asking them how they've used illicit substances in the past. I know we're at time. I don't know if there are any other questions though.
It doesn't look like there's any other ones that came through.
All right, I don't think we have any other questions. If you do want to send us or email us a question or you need something in follow-up, you can just reach us through the CCPC. And again, the website is listed there. Dr. Rao is going to be giving a talk sometime in the fall that we'll talk about substance use disorders, and maybe we can delve in a little bit deeper into some of these issues, because your question is not different than what we get a lot of the time. And with that, thank you for spending your dinner hour with us. I hope the rest of your evening is relaxing.
Thank you, everyone.